risk stratification in GvHD is a topic I'm interested for a long time. I'm here closely collaborating with Jamie Ferrara and John Levine, who are heading the MAGIC consortium in the US. We are heading the MAGIC consortium in Germany, and so risk stratification by biomarkers is an approach we are using in the last years with increasing evidence. So risk stratification can be based on two major categories. One is clinical risk stratification, and I think we had an excellent talk about from Daniel Weisdorf about risk stratification using the Minnesota criteria. We also heard from Francis Ayuk about the MAGIC biomarkers and the progress with the MAGIC biomarkers. My point in the conclusion was that we need to combine clinical and biomarker dependent risk stratification in the future. There are already planned studies which use both categories together. So we should have an increasing sensitivity of the predictors of the time course and of the response of acute GvHD. And I think the same is true for chronic GvHD. Stephanie Lee here summarized chronic GvHD biomarkers and risk stratification, and made the point that we are far behind in the context of chronic GvHD, which may be related to the complex pathophysiology of chronic GvHD as compared to acute GvHD. But independently, both in acute and chronic GvHD, I think risk stratification is one way to move forward. Currently, we all are using corticosteroids as first-line treatment of graft-versus-host disease. And then if steroids do not respond, both in acute and chronic GvHD, we start the next agent, calling it steroid refractory GvHD. However, if we come to steroid refractory GvHD, there is already a lot of damage in the patient, both in acute and chronic GvHD, and it might be wise to have risk parameters even at the time of onset of GvHD to modify treatment. This could be combined treatment in high-risk patients, and it could be reduced treatment or even treatment without corticosteroids in patients with a very low risk of complications by GvHD. By this, we hope in the future that we intervene earlier, risk-dependent, and thus can reduce a lot of damage which is ongoing until we reach steroid refractory GvHD. And we have to keep in mind that steroids itself are not only helping in GvHD, but they are also interfering with organ function. They are interfering with stem cell function in the gastrointestinal tract and may even impact and damage the repair which is needed for repair of GvHD.